Okay, if people would like to take their seats, we'll be starting the seminar shortly. Well, good afternoon. I'd like to welcome everyone to this 80th seminar in the Global Health History Seminar Series. This is actually the last seminar that I will be coordinating, as I'm retiring at the end of next month from WHO. And I think, it's been a great success to have had these seminars with the support of our collaborating centre at the University of York and the financial support of the Wellcome Trust. I think it's been one of the longest running sort of public seminar series in WHO. We started in 2004 with our first seminar, and as you see, we've reached the mark of 80 seminars. So today's seminar will have the same format as previous seminars. We have two speakers. One is our historian, and I'll be introducing her in a minute, and then we'll have a WHO speaker who will follow immediately afterwards. Afterwards, we'll open up for questions, both here in the audience here, and the seminar is also being broadcast on the internet, so there'll be people also on the internet who may are also welcome to ask questions. So our first speaker is Dr. Vanessa Noble. She's from the University of KwaZulu-Natal in South Africa, where she lectures in history. Her research focus is on the history of health and healing in Africa, and in particular she has an interest in biomedicine, and especially the history of medical education and professionalization, as well as community-oriented primary healthcare in Southern Africa during the 20th century. She's just recently published a book, and it's just recently been launched, and it's on sort of the medical schools of Durban and the education of black doctors. And I think there's a few leaflets around which were distributed, if anybody's interested. So with that, I'd like to ask Dr. Noble to make a presentation. Thank you.
Okay. 25 minutes or something. Okay, thank you so much for inviting me to be here. I'm very excited to be in the World Health Organization. I've never been here myself, and I have come across obviously the history of this place and coming across the influence of the World Health Organization on South African history more generally. So yes, it's a great pleasure to be here. Okay, so I've been asked to give a talk on the influence of the development of primary healthcare in South Africa. It's a complicated history, as I'm sure for many of the speakers you've had before, Mexico, various places that you guys have you've looked at. So I have only a short amount of time to give you a few interesting, what I think are interesting points about the development of this particular focus in medical history in South Africa. And the other thing I just want to mention is that I'm going to really focus on the 1940s to 1980s period. And that period of time for South African history was obviously the significance of the influence of apartheid in that era. So the development of primary healthcare within the South African context becomes very much influenced by race and racial inequality policies in this particular area. All right, so the talk today, in terms of the areas I'm going to focus on, are basically the following three issues or points. Okay, so very briefly, I'm just going to discuss or talk about the early 1940s, the development in primary healthcare in South Africa. It was one of the early sites where primary healthcare was developed in the world. And so there's just a couple of points I want to mention with regards to that. Okay. Right. The second thing I want to focus on is how the primary healthcare movement in South Africa basically became incorporated within a medical school environment, and particularly one medical school only, which is one of the factors that led to its demise as a key approach by the end of the 1950s. And then I want to focus on briefly leading up to Joseph's talk, what was happening in primary health care in South Africa during the 1970s and 1980s, when it was taken out of the institutional environment or national public health care policy environment and basically becomes an issue that anti-apartheid activists use as a mobilizing strategy in the anti-apartheid struggle. So it's as I said, it is a really complicated and convoluted story. Okay, so I wanted to start off briefly by sharing with you a few points about the beginnings of primary health care in South Africa. As with any context, there were obviously certain things going on in the country in the 1940s, but there were also certain international predecessors that certain progressive doctors in South Africa were looking to and being influenced by in places like China, for example. So a good example is the work that John Grant was doing in the Rockefeller Foundation in China. And one of our key chief health officers, his name was Harry Gear, in the 1930s, he actually went to China and learned about a very interesting and innovative, comprehensive primary health care center that was being established in a number of places in China, which this guy then, this chief health officer then took this information back with him to South Africa and started or encouraged certain doctors to start this type of comprehensive center in a South African environment. So what happened was basically this guy, Harry Gear, as chief health officer, employed two young doctors who just came out of the University of the Witwatersrand in Johannesburg, who were very socially conscious. They were professed Jewish by religion. Their families had been very much influenced by the Holocaust during, obviously, the Second World War. And during the early 1940s, these two individuals were basically given the task of starting a primary health care facility in South Africa. And they chose a site in a very rural part of the eastern side of South Africa in a place called Pholela, just below the Drakensberg Mountains, if anybody knows that area of South Africa, to start a center and basically pilot a project to see if it would be something that could be developed on a national scale. So this husband and wife team, their names were Sidney and Emily Kark, as you can see on the image, basically start this experimental primary level community-based facility in a rural reserve area, an African reserve area in rural Natal. Essentially what they did is they worked with a team. But what was interesting about this particular primary health care experiment was that it wasn't just doctors or even just nurses going out and giving healthcare services in a clinic, but it was basically a team of doctors, nurses, and increasingly individuals that they recruited from the local community of Pholela, who were basically born there, spoke the local languages, brought into the health center, trained on the job, essentially, and then sent out with this training. A lot of the training that they were given was promotive training, in other words, health education stuff. So they would go out into the communities and encourage people to, you know, how to protect water sources or build vegetable gardens to help improve nutrition. Also to spot early examples of disease, so for example TB or sexually transmitted infections, that there were certain signs that people could essentially identify. So there were these teams of doctors, nurses, and community health workers at a variety of different skill levels that were basically working together in this health center team, not only based obviously in the clinic, but also going out into the communities, talking to people at schools, talking to people at churches, and in their homes as well. Okay, so that's just showing you some of the health education stuff that was going on. What was key about Pholela too was that, as I said, the crop farming, teaching people, you know, protecting their crops from erosion, what sorts of nutritious vegetables would be grown in the particular area that would help to improve nutrition. So this health promotion, this health education related angle was very important in terms of this early training and service provision in the area. Basically what happens is by the 1940s, this experiment starts in 1939, 1940-ish. By 1945, actually even earlier, 1944, a National Health Services Commission gets appointed by the national government to basically figure out a way in a very reformist Second World War period in South Africa's history to try and figure out a way to actually improve healthcare services across the country, because there was a lot of preventable and communicable diseases that were mushrooming in many of basically the segregated African reserve areas, which was basically spreading into many of the urban centers and affecting people of all different races. So there was this idea of obviously trying to figure out a way to improve services and possibly using this as a model to develop a national healthcare service. So this is basically what happens in the mid-1940s. The government at the time decides that the statistics that come out of this experimental case study basically significantly reduced many preventable diseases, particularly ones that were also infectious and obviously communicable. And so they used this, and I'm just basically telling you this in a nutshell. I don't have time to go into details. But they used this as the basis of a model to basically roll out a series of comprehensive health centers across the entire country, okay, from 1946 onwards. And, okay, so it was basically this Palela Health Center was the first comprehensive health center service of its kind. It led to, sorry, I forgot to bring these up when I was talking, significant reductions in preventable and communicable diseases. By the 1940s, it starts getting rolled out as a model, okay, at the national level. And what I just wanted to mention at the end of this slide was that they also create what becomes known as or named as the Institute of Family and Community Health, which is basically created in one of the primary cities or key cities in the east side of South Africa, the city of Durban, which I'll show you in a map now. As a training center for these doctors and nurses and community health workers that were going out to staff these health centers. So, for example, doctors and nurses would use this or go to this place as a postgraduate diploma course that would run from, say, 3 to 6 months. And the community health workers who were very geared towards prevention and health promotion were sent there for, depending on what they were doing, if they were going out to do survey work or going out to do health education work, their courses extended from 1 to 3 years at this particular facility. And I'm going to talk more about this facility now because it becomes linked to the medical school, which I want to talk about in the next few slides. Okay, so we've got this going on at the national level in terms of South Africa's primary healthcare development. Okay, on the left, or my left, there's a map which is basically just showing you the whole of South Africa at the bottom. And the region I'm talking about is that eastern side, the province which was then known as Natal, today it's known as KwaZulu-Natal. And particularly the Durban metropolitan area, which is the yellow area, is where this medical school and where this Institute of Family and Community Health became located and would provide the training base for these individuals that would then go out to basically staff these health centers across the country. All right, so despite these initiatives, what is interesting about the history of primary healthcare in South Africa is that the debate about incorporating primary healthcare as a key focus area in South Africa's established medical schools did not follow suit, okay? In fact, what ultimately happened was that race came to infuse or permeate the story of the development of primary healthcare in South Africa. In a context where there had been a long history of training doctors, most of whom were white in the country, and by the 1940s, up to 95% of the doctors in South Africa were white or of European descent. So this long history of training doctors to practice a curative form of medicine, very much disease-orientated and hospital-based, much in line with first-world biomedical models being taught to students, and obviously having very strong connections to places like Britain. There was very little interest in changing a tried and tested formula of introducing primary healthcare approaches in the medical curriculums more generally. If a primary healthcare orientation was to be developed for doctors at the medical school level, it would need to be introduced at a new facility, okay, a new school, which is exactly what happened in the formation in 1951 of the country's first black medical school in the city of Durban. So that's just showing you an image from the 1950s of South Africa's first black medical school that was created, and where this experimentation in training medical doctors in primary health care basically gets launched, okay, in the 1950s era. This is just showing some images from the medical school archives of young doctors in training in the labs, and then obviously in a variety of tutorials and around cadavers. Okay, now a strong motivation to build this medical school in Durban, all right? And this medical school, why I'm telling you about it is firstly, it's an area very close to my heart. I've done a lot of research on this place. And so the connections, just very interestingly enough, have been with this medical school and primary health care have actually been quite strong in terms of South Africa's historical development. So the strong motivation to build this medical school in Durban was that those who wanted to create the school basically thought it would be a good idea to build it in Durban so that they could link it to this Institute of Family and Community Health. So they could actually develop the school as a new approach to the training of doctors in the country. The aim was to use the institute, and it had a whole bunch of, I think it was 7 or 8 health centers attached to it, okay? That some of them were in rural areas, some in urban areas, some in peri-urban areas, as a practical training base in primary health care. So in other words, this institute and its health centers were going to operate like a training hospital, but in the community, okay? Essentially what happened is that between 1956 and 1960, I'm just moving along quickly, is that the Rockefeller Foundation, obviously an American philanthropic organization very interested in medical education, had come across these early doctors, the Karks, interestingly enough, about 10 years earlier. The Karks had actually got a training in America in certain forms of primary health care. They knew about the Karks. The Karks were actually brought to Durban to run the Institute of Family and Community Health, and the Rockefeller Foundation essentially gets approached to ask if they'd fund or create a package to provide funding to help with a formal affiliation between this institute and the then University of Natal, which was the controlling body of the medical school. Okay. So this package gets negotiated. Kark agrees to essentially join the academic staff of the medical school. And then his position is created to basically become departmental head of a new Department of Social, Preventive and Family Medicine at this medical school, which was obviously not being offered at any other place in the country at the time. Okay, now as head of this department, he introduced a number of significant curriculum changes, okay? Just to give you some examples, there are others, but I won't have time to look at them, is, for example, if we're looking at comparatively what was happening in Durban at this school and other places like in Wits or Cape Town, for example, which were the big established medical schools in South Africa at the time, this medical school extended its curriculum, for example, from 6 to 7 years, okay? And this was largely done to make way for additional human and social science subjects, but also psychology subjects that the preclinical students had to take, okay? So, for example, they had to learn history, and particularly history of medicine stuff. They did stuff on sociology. They did stuff on cultural and behavioral aspects that influence health. There were a variety of things that the other medical schools that were focusing on basic science subjects were not focusing on, which were being pushed at the school at the time. In addition to these extra subjects students had to study, the training at the medical school was partly hospital-based, so they still had a training facility at a hospital where the students did the major subjects of medicine, obstetrics and gynecology, and what was the other one? Surgery. But they, in addition to training at this the teaching hospital in their clinical years, they also had to go out into the community and basically to this institute and its health centers and learn on the job in terms of training with these health teams that were going out into these a variety of health centers and into people's homes. So it was a whole other level of training that was outside the teaching hospital walls that these students were being given in their clinical years. I just included an interesting quote here from Sidney Kark. He was interviewed in the 1980, and this was part of the university's archives. He said, "We began a new approach in which we decided that we needed to know the people we were dealing with. This meant that we needed to meet them in various situations, not only in clinics. We had to visit their homes, we had to meet them in the fields, we had to go to their schools. This gave us insight into their living. It also made the people realize that we were different kinds of creatures from the doctors that they had met before." All right, so during the 1950s, basically in the first 10 years of this medical school's existence, as a very fledgling and, finding its feet in this situation, instead of following the conventional educational trend of growing specialization, largely hospital-based medicine, it committed itself to a very different approach and was actually starting to blaze a new trail in medical education in South Africa in these years. It taught students how to, for example, prevent diseases, to appreciate the biomedical but also wider socioeconomic, environmental and cultural causes of diseases, and actively sought to promote good health through health education strategies in community spaces beyond the walls of the teaching hospital. However, unfortunately, this unconventional institutional effort to train students in primary health care in the 50s at a single medical school did not last very long. By the 1950s, late 1950s, there was mounting antagonism from many quarters, for this primary health care teaching approach at the medical school. Some came from a number of doctors, many of whom were white, as I mentioned earlier, who objected to the negative effects the state's preventive and promotive healthcare program was having on their bottom line, their profits, basically, because then with disease being increasingly shut down in certain areas with these preventive and promotive approaches, these doctors were not obviously making as much money. And increasingly, too, from growing numbers of reactionary apartheid-era politicians who spoke against their predecessor government's health centre movement, as well as its key practitioners for advocating what they considered to be leftist-leaning socialist forms of medicine. In an era of heightened anti-apartheid rhetoric during the Cold War era, so that 1950s period, the South African State's association of social medicine with socialized medicine was based on Kark and his team's free distribution of food and milk to the poor and malnourished within the health centers that they worked in, many of whom were also black South Africans. During the late 1950s, the apartheid government basically increasingly cut funding to build new health centers. They reduced their funding to maintain existing health centers, including the nest of liberals at the Institute of Family and Community Health, and they limited the funding for the employment of health personnel at a variety of health centers across the country. The one doctor who trained in Durban in the 1950s, she graduated in 1957 and went through Kark's training. She told us, or she told me in an interview, that for one thing, they were bringing to the surface the lot of black people, and I think they, the state, felt that they, the teachers, would have an influence on students and maybe even their patients and the communities. You see, you must remember also that no other medical school had this subject, and here was a black medical school that had this special subject about social and community health. And they could have seen it as a threat, that they were training activists and things like that. Although Kark and his team might not have regarded themselves as political activists at the time, their work had political undertones that advocated what medical historian Sheila Marks has argued was a more liberal and liberating medical practice, which inspired many young medical students and the black communities they served. Kark and his team's approach were emphasized bottom-up, community-based, and orientated approaches, which encouraged patient empowerment through health education and focused on the deeper socio-economic root causes of diseases, many of which were caused by apartheid policies, of course, and which made the state really nervous and represented a huge leap beyond the thinking of most government officials and certainly many of the white medical profession at the time. So what happens is basically from the late 1950s, many of South Africa's primary healthcare advocates, under increasing harassment by the state and funding cuts to their programs, start leaving the country in large numbers. A good example of this is the Karks who left for the USA in 1958, where Sidney was invited to initiate a new department of epidemiology at the University of North Carolina. A year later, they left from this place and they went to Jerusalem, where they joined the staff of the Hebrew University Hadassah Medical School, where their primary healthcare ideas found receptive ground. This period also sees the beginning of Kark's 25-year association with the World Health Organization, as he became the WHO Professor of Social Medicine and Public Health at this Hebrew University between the late 50s and the mid-1960s, and continued to be right through until the 1980s a consultant and expert on a variety of World Health Organization committees on public health, medical education, community health, primary health care, etc., etc. So while South Africa was increasingly turning its back on social and community medicine approaches, the world gained from the relocation of these primary healthcare experts. In more politically supportive environments, the Karks and their colleagues built upon the lessons they had learned in South Africa and achieved international recognition. They established comprehensive health care centers, developed innovative undergraduate and postgraduate programs, mentored many who traveled great distances to come to these places of expertise, and then would spawn similar projects in other parts of the world. This ultimately led, as many of you know, to the 1970s developments in community-oriented primary health care, which was obviously officially endorsed by the World Health Organization in 1978 at the Alma Ata Conference. Of course, the loss of the Karks and many of their colleagues had very negative repercussions for South Africa as the decades went on, and as primary healthcare services and medical education remained increasingly inadequate to address the country's major healthcare needs. What's also sad is that the Rockefeller Foundation's funding dried up at the end of 1960, and this is the same year where South Africa went through the Sharpeville massacres, where many police shot at black South Africans in the townships. And there was a growing concern, and this obviously American organization, that South Africa was on a path towards totalitarianism of a right-wing variety. So funding dries up. The institute essentially in Durban and many of its attached health centers, as well as other health centers around the country, either get closed by this early 1960s period or converted into curative clinics. So the health promotion and the preventive side is essentially scrapped. And while attempts were made to continue teaching aspects of social and community medicine at the medical school, by 1962 this too was phased out, bringing it into line with the educational models of the other white medical schools at the time. In fact, it would take many years until the 1980s before there was a sustained focus on primary health care and community health services again in the formal curriculum, when a new Department of Community Health was established. Until then, primary health and a primary level comprehensive health care was not a priority of the school's curriculum. Instead, like its colleagues or schools in other parts of the country, the curriculum remained until the 1980s overwhelmingly curative and hospital-based, and in fact increasingly geared towards specialization and fragmentation. All right, so just very briefly, what was happening in the 1960s to 1980s in terms of primary health care. What's interesting is that from the 1960s onwards, after these experiments had basically been squashed, medical students who were interested in primary health care in a variety of places around the country were required to explore such issues outside of the formal medical curriculum. Okay? In other words, they had to start their own reading groups. They had to attend, some of them did conferences in countries overseas or created their own ones in the country. Some also, in terms of the curriculum, could do postgraduate diplomas, but basically the undergraduate degree was not geared towards primary health care. Also, some students were introduced to primary health care through their anti-apartheid political activities. In fact, what's interesting about South Africa from the 1960s to the transition period of democracy in 1994 is that the quest for primary health care became a highly politicized issue, and one largely associated with anti-apartheid activists who used the issue to campaign for more affordable, equitable, and accessible health care for all. When we returning briefly to the medical school itself in Durban, this student body, which as I said is my primary focus area in terms of my research, became highly politicized from the late 1960s. These students at the separate, racially segregated school basically endured incredible hardships and hurtful indignities and racial inequalities in terms of their training, where they were allowed to stay, what lecturers would say to them in classes, the unequal non-European training facilities at their teaching hospitals. All of these things basically provided a huge amount of fuel, which angered and frustrated many of them, and provided thus a fertile breeding ground for anti-apartheid sentiment and action at the site. During the 1960s and 1970s, many Durban students actually joined an organization known as the South African Students Organization, or SASO for short, which was basically, it developed over time as a Black consciousness organization. In other words, an organization interested in liberating Black South Africans from what were argued to be the psychological shackles that bound them to a sense of inferiority under apartheid, promote positive self-worth and pride, as well as developing a sense of empowerment and self-help amongst Black South Africans. At the school, one doctor who trained in the 1970s, who was actually influenced by this SASO Black Empowerment Organization, she told me in an interview that, you know, we were young when you've just arrived. Now she's talking about coming to the medical school. And the people who were already there wanted us to know exactly who you were. It was not just about medicine. So they told you about the studies, but at the same time, they told you a lot about life. I mean, I learned to be an activist at medical school, and I learned to actually understand what was happening in the country and what we should be doing to correct the ills. This is just showing you some images of the protests that went on at the medical school. During the 60s, between the 60s and the 1980s, there are many, many counter stories about Durban medical students protesting in a variety of different formats. They protested broad anti-apartheid inequalities, university-imposed inequalities. They, marches, strikes, boycotts of lectures. Students were harassed, beaten up, arrested along the way. As part of their activities, however, SASO activists who were obviously involved in broader things, not just community health stuff, they also got involved in community development work as part of their activities. They worked with other Black consciousness organizations and other NGOs to basically raise local and international funding for this development work in South Africa. And from the early 1970s, a variety of student activists, including these medical students who became involved, initiated a number of projects around the country, which included, for example, literacy campaigns, helping to build durable homes, and providing and protecting clean water supplies, for example, to promote good health. Black empowerment was a key issue for these students and SASO activists more generally, and they went into communities with the aim of providing people with the necessary skills to encourage self-help, as well as to empower them people to take responsibility for their own health. As Nkosazana Dlamini Zuma, who was our first Minister of Health, now chairperson of the African Organization for African Unity, the idea was to popularize SASO and Black consciousness not by talking to people and telling them, but by physically being there and with them, sharing ideas with them, and working with communities to help themselves. Obviously, these ideologies fitted in nicely with development of community health projects, which is clearly documented in many SASO and Black consciousness reports. And also what's key about this particular initiative is that it was largely based around volunteer work, where students, for example, if we're just looking at the medical student body who became involved, would work on weekends, as well as in their holidays on a roster system to essentially go out into these community places to offer their skills and services. And many of the communities that they went out into in the Durban and larger KwaZulu-Natal area were very low, poverty-stricken individuals, basically impoverished communities, Indian and African and colored communities in the particular province. At these particular clinics, the students provided, this is obviously mostly clinical students, so they've got beyond their preclinical years. They would work with volunteer, fully qualified doctors who were also volunteering their services to provide basic curative services, but in addition, also focusing on prevention and health promotion activities at these sites. In a report of the SASO National Executive Committee in May 1974, it was noted that preventive and protective medicines is without any doubt the most important part of this field of our operation, even more than healing and treatment of patients. Now, just returning to one of the doctors I mentioned earlier, May Mashego, who was there in the 1970s during the SASO period of time, she told me in an interview that, you admit this child today and he's got quashed, you give them good food and you send them home. But where are you sending them? They'll come back. So this was what was happening, what you were faced with as a Black doctor, the type of diseases you were treating, the type of people you had to sit and look at suffering, and all you could do was just treat them. This is why some of us couldn't shut up. Okay, unfortunately, despite their best intentions, the SASO community health initiatives tended to be of limited scale and beset by many problems. Obviously, staff shortages were key, limited resources, limited transport, lack of experience of students doing this sort of work, the transitory nature of student bodies. In other words, they come, they do their service, their community work service, and then they leave. All of these things had a negative impact on the success rate of these community health projects. In addition, the enormity of the socio-political problems and great poverty faced by many of the communities they went into were certainly not something that idealistic students committed to their work could essentially solve in the amount of time and with the resources they were given. Rampela argues, also a student, she was also a student in South Africa in the 1970s, that, for example, when students went to work in this community called Winterveld, the students were shocked by the level of poverty they encountered there and the enormity of the problems people had to deal with in the separate development reserves. In addition, they had not prepared themselves for the bitter fruits of powerlessness that plagued so many poor areas, nor had they readied themselves for the huge problem of apathy and despair that enveloped people in these communities. So for this generation of students who were involved, the problems were enormous. It certainly opened their eyes further to the inadequacies and inequalities of apartheid forms of medicine, and gave them experience in practicing medicine away from hospitals, but as I said, the desperately needed healthcare services and skills that were actually needed, it was not enough in terms of what they could provide. However, some people like Mampela Rampela, who is now a politician, who's the party known as Ahang in South Africa. She stood for as part of the elections just in recent months. She's also a doctor, a businesswoman, author. She played a prominent role in SASO leadership in the 1970s and was so inspired by her student days, despite these incredible difficulties in these community health projects, that after graduating, she actually went down to the Eastern Cape, and together with some other doctors, she helped open a community health center in King Williamstown in 1975. The Zanampelo, which is the one I'm showing there, it's not the greatest or clearest. And then in the late 1970s, early 1980s, she opened another community health center in the Zanin area of the northeastern Transvaal. So there were certainly initiatives by students once they graduated. So moving swiftly along now to the 1980s, how's my time? Okay, thank you very much. What's interesting about primary health care, and I'll just cover this really quickly because I think Joseph might talk about some of these things as they link up, is that with primary health care largely being squashed in the medical school environment and in the national public health care policy area, a number of anti-apartheid organizations, as I said, picked up the drive to promote primary health care as a political issue. And so the primary health care flame was kept burning by a variety of organizations in the 1980s that were obviously non-governmental and non-medical school organizations. And when the Black consciousness organizations like SASO were banned by the state, these other non-governmental organizations basically were key in keeping the idea for primary health care alive. There are a number of organizations, I won't have time to talk about them. The United Democratic Front was basically aligned to the ANC, which was exiled and banned at that time, but it was an organization that worked on promoting health as well as a variety of other issues, education, for example, cultural aspects of South African life. The National Medical and Dental Association was also formed in the 1980s as a lobby organization to promote an end to apartheid in medicine. And the National Progressive Primary Healthcare Network was also a key organization that was basically publicly criticizing the abusive and racially unequal and unethical practices of apartheid in medicine, and promoting primary health care at this stage, though only in small-scale pilot projects to try and essentially encourage it as a national strategy for South Africa. So there are a variety of these things going on essentially in the country in the 1980s. By the early 1990s, essentially the years leading up to democracy in 1994, just a few points I want to mention in terms of just tracing the final part of this talk. Basically what happens is that primary health care became the foundation of the new ANC government's National Health Plan for South Africa in 1994. So what is interesting is that I just wanted to give you one example. One of the people who was trained in Durban, her name is, as I've mentioned before in this talk, Nkosazana Dlamini Zuma, who became our first Minister of Health in 1994. She had interestingly grown up in Kolela, where the original experiment started. She received most of her training at the medical school in the 1970s before she was forced out and overseas to complete her medical degree in the UK because of involvement in SASO anti-apartheid political activities. And she worked for the ANC health activists in exile until the ANC was unbanned in the early 1990s and led the way in advocating primary health care as the way forward for South Africa's National Health Plan, becoming the Minister of Health, which then was the person that essentially helps in implementing this policy in the country. Right, so primary health care becomes the foundation of the ANC's new National Health Plan. Essentially, the aim is to improve health care for all, not just for certain people within society. And as part of this change in the 1990s, medical school curricula, returning to the subject of medical schools again, are increasingly encouraged to reform because many of these schools are subsidized by the state. to change their curriculum to have a higher primary healthcare and community-orientated approach. This starts happening in all the medical schools in the 1990s and the 2000s. The problem is that transformation of old healthcare systems, okay, and the implementation of primary healthcare has been incredibly difficult in the South African context. There have been many problems. Just to give you an example, in the 1990s and 2000s, there has been a diverse amalgam of factors that have negatively affected the implementation and rollout of primary health care, from the high rates of medical migration of doctors and nurses to severe health worker shortages, deep-seated imbalances of resources and inequalities in the distribution of personnel, a highly fragmented healthcare system with Bantustan or separate development areas and the urban areas, a complex and evolving burden of disease, not to mention HIV/AIDS, which has sapped a lot of the resources for the country's primary healthcare services, and healthcare and deficiencies in managerial capacity issues at leadership of all levels has continued to limit the achievements of primary healthcare in the country today. So, this is my concluding slide. Was primary healthcare a harbinger of democracy in South Africa? Looking back with hindsight, as us historians are able to do, I would say it's a qualified yes, okay? Because certainly primary healthcare from the 1940s experiment I spoke about earlier today, it was a forerunner, it was an indication, it was a sign, it was a precursor of what was to come in the post-apartheid period. But it was both in the past and today, it has not been easy to implement this primary healthcare approach in the country. The story of primary healthcare in a post-apartheid South Africa is a history full of complexity, okay? There are reversals, steps are made forward, but steps have also been, taken in reverse, and incredible contradictions. And it's basically a story that still needs to be comprehensively written, because obviously we're living through it now. So I've lived, I've been alive and living in the country during the last 20 years of democracy, and the enormous problems of trying to roll out this primary health care in the context of HIV/AIDS, for example, has been incredible. So it's a story that I haven't written. I don't even want to touch it with the barge pole yet, because I feel like as a historian, I want to just get more distance to be able to judge the changes in time. But yeah, it's the policy people and the sociologists and a variety of other scholars have been starting to tackle this history. So it'll be interesting to see what Joseph says in terms of policy stuff in the more recent past. Thank you very much.
Okay, well, thank you very much, Dr. Noble, for a very interesting talk. I say we'll hold questions until we hear the second speaker, who is Dr. Joseph Kutzin, who's a coordinator in the Department of Health Systems, Governance and Financing here at WHO.
Thanks, and I want to also thank Dr. Noble for her presentation. It was a good reminder for me, even that my undergraduate degree was in history, and I only went into economics for vocational training. But it's good to know you can get work also with doing history. One part, I think, as well, in a way that we're talking now in terms of both health financing, which is what I work on, and UHC as well. Most recently, in a sense, that a lot of what countries need to do in order to really make significant progress was to change history, in fact. And this is kind of an important message here, I think, as well, meaning literally a lot of things can change on the surface and even inside some of the details. But a big challenge to deal with is simply the core structures that are inherited from the past, both the bureaucratic side of things, but a lot of the entrenched systems that exist in many countries. And a lot of our agenda in universal health coverage really has to take that on. So it's not just kind of some of the technical issues, but really looking at all of these institutional structures. we did not, this is the first time I'm seeing Dr. Noble's presentation, so we have not shared much of anything as yet. And so in making an attempt to reflect on what she said, I had to prepare that before knowing what she was going to say. But basically what I thought I could do is look a bit more at a macro level of where things are today, and particularly from my background in financing and looking at expenditure patterns, and then see what kind of conclusions or issues I might put on the table in terms of understanding the nature of the challenge and why actually this concept of universal coverage is especially relevant in South Africa today, despite what may seem on the surface like maybe it's not a big problem. Okay, so broadly I'm going to cover these three types of issues in my talk, looking at expenditure patterns in South Africa more from a global perspective. The second point is really what we're here is a lot of this issue of fragmentation and really the structure of systems. It's not only a South African problem, but it manifests itself in a particular way there. And again, looking at what this means and thinking about the case of South Africa in the context of how we think about universal coverage. So first on the expenditure patterns. In general in financing, well, first of all, just to say in terms of, when we're using this term universal health coverage, part of making this a practical concept is transforming, in a sense, the definition into some concrete objectives and talking in terms not of achieving something, but making improvements along those dimensions. And here, basically saying that within this definition are the objectives, these three objectives. So it's about reducing the gap between the need for and use of services. So this is another way of saying equity in the use of services, to improve quality and to improve financial protection. It gives and many people have said, well, is this just about treatment? We say, no, it's not. It includes a whole range of services that people may need in terms of promotion, palliation, and so on. But this is simply how we present it. And similarly, these objectives around improving quality and improving financial protection. And the last one, that no one becomes poor as a consequence of paying for health services. So usually when the economists, financing people like myself look at this, we're mostly focused on this issue of out-of-pocket spending that raises important concerns about both financial access to care as well as the financial consequence of using care. And it's typically linked in global patterns. High dependence of systems on out-of-pocket payments tends to be linked to relatively low levels of public spending on health, which in turn is often linked not only to a country's limited fiscal capacity, but also just simply giving low priorities to health and public spending. So with that, this is what I'm going to show is sort of how we look at lots of countries, but in this case, to look at South Africa. So first, and in this chart is simply government spending on health as a share of GDP. The red line is, this is from our database for the most recent year, which is 2012. So this is the average across all countries in the world. Governments spend almost 4% of GDP is being spent on health. The countries I have here from the Africa region, and South Africa I've highlighted over here. So South Africa spends a bit more than average, not just for Africa, where it's over here towards the right, but a little bit more than the average country in the world. So it seems to be doing okay in terms of government spending as a share of GDP. And in terms of priority, one would not say, again, that the South African government has given a low priority to health. This is the share of health in total public expenditure. So again, South Africa is, sorry, I'm trying to use this as my pointer, is doing relatively well along this dimension in terms of the priority that the government is giving to health, and this has been fairly stable. So in a sense, and finally over here, on average, countries in the world have about 34% of total health expenditures out-of-pocket payment. We see in our data that when out-of-pocket spending gets above 20% of total health expenditure, it does tend to be associated with fairly significant problems in terms of financial protection. People really tend to have a greater likelihood of falling below the poverty line or going deeper into poverty as a consequence of health spending. But if you see all the way over here, this is not a problem in South Africa, according to the data. Okay, so we're trying to figure out, so what's the problem, in a sense? This is a relationship between government spending on health, as I said. So in this message is simply what we often see, that while there's a lot of variation, in general, the more governments spend on health, the less people spend in their own pocket. And South Africa seems to be doing very well. So the question is really, what's the problem? And you give an economist enough time, we'll find some problems. In this case, this is one thing where South Africa is really an outlier. And it's here. This is the share of voluntary health insurance. In South Africa, it's called private medical scheme coverage. So the share of total expenditures that flow through this route. And South Africa, in this chart, is every country in the world where with at least 5% of total health spending coming through voluntary insurance, which you can see is not a lot of countries. But South Africa is the biggest. And in fact, if you look at some of these other countries, there is a particular Southern Africa pattern. So you see Botswana here, Namibia as well. So there is an issue of the historical development here in which these medical schemes develop largely for the white population and so on, as separate from the rest of the system. And that continues. And South Africa, you see, is a bigger share than the United States. I'll come back to this point in a minute, but basically, if you think about this, in fact, in the United States, which is where I'm from, I mean, one of the critiques is the unequal consequence of the private insurance system. Yeah. I could hear you.
Okay.
I don't know if the people online can.
Oh, all right. I'm not an economist, but so do I read that 42.2% of South Africans have a voluntary insurance?
No.
Okay.
No, I'm coming to, actually, it means 42.2% of total health spending flows through private insurance. Yes, private voluntary health insurance. Why that is important, though, coming to your point, is that, for example, in the United States in that year was about 33%. That 33% in the United States served about 65% of the population who had private health insurance. In South Africa, this 42% is on behalf of 16% of the population who has private medical scheme coverage. So when you put those two things together, you get this is really a reflection of a great deal of inequality that, going back to the objectives of universal coverage, where we're talking about equity in the receipt of services relative to need, the fact that 42% of health spending is on behalf of just 16% of the population, and that part of the population likely to be not the poor, let's say, and probably maybe with less health needs, is a reflection of a real extreme type of inequality in the system. Okay. Now, what we see from international comparisons, and what this means is basically, this is just for a number of different countries. The blue part shows the share of total health spending that comes from mandatory prepayment. That effectively means taxation of any type. It could be, VAT, income tax, compulsory contributions to what's called social health insurance, payroll taxes, basically. And in general, these countries over here, which all tend to do well by international standards in terms of really providing an effective funded guarantee to their populations, tend to have at least 70% of health spending in this blue. But these here, like the US and South Africa, a big share. And again, these are some of the biggest shares of all coming as voluntary health insurance, even though the out-of-pocket payment share, which we tend to look at more, is not such a big deal. The voluntary health insurance share in these countries, the red part, really does make it a big deal. Just to give you an idea, these are not all sort of European countries or Japan. We have Cuba, for example, here at the end. Thailand also doing well. Qatar, Costa Rica as well, Turkey. So there's a range of different types of countries. What these countries don't have in common, basically, is the large share of funding coming from compulsory sources. The countries to the right in this arrow saying this is kind of the way we're encouraging countries to move, is that. So what one study has shown in South Africa is this, and I'll come back to the issue of need later, but from the Health Economics Unit at the University of Cape Town, they've done this analysis where they've been able to, doing some survey work, estimate need and relate that to income, and in a sense saying, you know, that the poorest 20% of the population had about 30% of the need, but was only getting about 10% of the resources, and so on. So there was seeing the consequence of this peculiar health insurance market in South Africa, which is a legacy of the past. And this is part of my attempt to draw this connection, but it is something that 20 years since the end of apartheid has not changed, and in some ways may have gotten worse, is still there, and it's still resulting, despite the best of intents, it's still resulting in this very unequal distribution of health system resources. It's not that people shouldn't necessarily go out on their own and buy health insurance if they can do it. The problem in this context is that given the labor supply in the country, it tends to drain away the human resources to serve just the insured population. It does create scarcities and quality problems in the rest of the system. So there's an interaction between the public and private parts of the system. So this is coming here, which is the idea of this enduring legacy of the apartheid system in health. And just to come back to the international agenda, one thing we talk very much about in our engagement with countries and in international fora is this problem of fragmentation, and that in order to really move forward on the UHC agenda, at least the financing aspects of that, the idea is to reduce the barriers to redistribution within the financing system, because the idea of improving equity in the use of services relative to need is that you have to have a system that enables redistribution of prepaid funds towards those with the greatest needs. So how to address the problem of fragmentation is a challenge that many countries are facing. And again, here, this idea that really enhancing these cross-subsidies is a critically important issue. And it manifests itself in different ways. This is a picture from Thailand in the early 90s showing the distribution where the public policy had led to the creation of different schemes for different population groups. So there was something for civil servants, the private sector workers, a low-income card, a scheme for the elderly, and a subsidized voluntary health card. And what you can see here is that, in part because of their power and influence, the civil servants and the private sector workers were able to extract a much greater degree of subsidy per capita than the rest of the population, even though one could argue that the rest of the population needed more in that sense. Whoops, I don't know how, sorry, that was not supposed to happen. Let me see if I can, okay, good. I learned something new. This is a picture. It doesn't look like Mexico, except for maybe the background colors and flag and so on. But what this is, we saw in Mexico in the mid-90s and a lot of Latin American countries. And without going into detail, it again is this historical pattern of basically creating health systems by social group rather than by function. And it's a bit of a legacy of how countries have inherited the historical development of health coverage in Europe, which began, for example, focusing on the formal sector workforce. And while in Europe that has spread, in some other countries, in Japan and to some extent in Korea, that has spread to the rest, in most low and middle income countries, it has frozen and basically, in a sense, beginning with whatever the existing inequalities there may have been in the society, basically put a health system in place that magnified those inequalities, that actually made it worse. Basically because the employed population, again, tends to be better off, and this is the formally employed, of course, tends to be better off than the rest of the population economically, also much better organized. And so their next move is not to generously extend the same benefits to the rest of the population, but to lobby for more subsidies and more benefits, often at the expense of the rest of the population. So this is another way that systems have been fragmented, which is effectively by magnifying existing underlying social inequalities. And this I show in part because I worked in the former Soviet countries for a long time, but also to say that the problem of fragmentation is not just one of things called insurance. It can also occur and does occur in a context of administrative decentralization. And here you had each level of government effectively funding and operating its own health system. And when you come to the capital city of any of the regions in those countries, you tend to find the city children's hospital and the Oblast children's hospital and the city maternity hospital and this plethora of infrastructure, which is all overlapping with each other. So they have a huge efficiency problem arising from that fragmentation and overlap. So in South Africa, coming back to this, I mean, so in a sense, from the global kind of perspective, fragmentation is always a problem, but there's not a unique way to deal with it because how it manifests itself is different in different places. And so part of our approach is to really understand what is the specific nature of that fragmentation, and then based on that, how might it be addressed? The estimates from South Africa, as I said, was really around this fragmentation between the insured and the rest of the population. The minister, I think he is still minister at the time, talked about this, that we used to, you know, segregate according to the color of your skin. Now it's according to the depth of your wallet, is how he put it. So it is, although there's obviously a lot of overlap there as well. But basically, you still have this very serious inequality problem that comes out of this enduring structure. The estimates that were made is here that about the insured get about 4.5 to 6 times the amount spent on them per capita than the rest of the population. And again, this is not only about money, it is about scarce human resources, other inputs. It's a very, and going back to the first presentation, the main, you know, this part of the medical system is heavily medicalized, heavily tech-oriented, and so on. And as a result, it's not, it is obviously an inequality problem, but it's very much an efficiency problem. And addressing this is very difficult for the government now. They have a big reform agenda under the label of national health insurance. But as you can imagine, there are expectations that, you know, we want to level up to the best. But the best, at least, are not really the best, but the most expensive. And that's where there's an important, I think, educational agenda to go, you know, in terms of giving people this history. Because if the whole system was to move into the system that serves the currently insured, it would be completely unaffordable. They'd never be able to sustain that level of expenditure. It might be bad practice as well. Now, in terms of need, that diagram I showed before where they used a household survey for self-reported need, this is just from some of the work also from the Health Economics Unit, where they identified basically based on various analyses needs of the sort of the poorest 10 or 20% of the population relative to the richest, just to demonstrate also through other mechanisms that it's very clear that that distribution of spending is just not reflecting need. Okay, it's clear that the poor, who are least likely to be insured, have much greater health needs along a whole range of dimensions, as shown here. So, in the plan, and one needs to take care always with labels. The reform agenda in South Africa has the title, as I said, of National Health Insurance. It doesn't actually have much to do with financing. It has a bit to do with financing, but the main thrust of it has been service delivery reform and actually strengthening primary health care, in fact, has been most of it. But there is a financing element, of course. I have to say that because I have to keep my job. And a lot of it is simply that, okay, given the nature of fragmentation in South Africa, the financing agenda comes down to how do we get some of that money that's serving the 16% of the population to work on behalf of everybody? So it's about seeing, you know, is it possible to introduce some mechanisms that enable some more redistribution out of that relatively small group and put that more to work on behalf of everyone? So as I said, that's kind of, I won't go into the details of what they're planning, in part because I think it's still quite contentious and under discussion. But just to say, going back to again, the political links that Vanessa drew in her presentation, you know, in this, we should be, at least if we're not being able to, we can say it publicly in some cases, not in my own country, but fundamentally, if we're talking about a redistributive agenda and reducing fragmentation and pooling, then you are talking about politics. Whenever you're talking redistribution, you're talking politics. And so it is how far a country is willing to go, what is acceptable. It may not be possible to put all of that money that's in private health insurance now in South Africa and make that subject to full redistribution. But, you know, this is at least moving to some extent in that direction is very important. But as was shown, and as I believe, even though I'm a financing person, if there is such a thing, it does require a lot more than financing to make progress. And you heard, I mean, I'm not going to get into any of the details of the whole kind of social medicine agenda that was shown before, but it's just clearly the broader context and kind of concepts that we portray in our dialogue with countries, and again, in various settings, that, you know, financing is very important. It's an indispensable part of the agenda. It's particularly important for looking at financial protection, but a big part of what people spend money on is medicines, and so medicines policy is also critically important. Improving equity and access to care. Again, financing is very important in terms of financial barriers, but that won't do much unless you have the human resources out in the places where people live, unless the services are there, and so on. So it's about how these things combine. And quality financing can do a lot of harm. It's not always clear that we can do a lot of good with our financial incentives, so that's something we're still working on. But fundamentally, that's in other aspects of the health system where things need to come together. And this last point, I just wanted to say, there's an important analytic agenda that countries need to take on board and strengthen, in a sense, the domestic links between analysis, evidence, and policy making. No matter how good our planning is, it will never be perfect. And so there's always some need to adjust, adapt, and make, you know, sort of mid-course corrections. And that doesn't go away. I mean, that's the nature of health policy. There's a great illustration, and one of the countries we often highlight a lot as our poster child for universal health coverage is Thailand. And a lot of attention here, I should say here in 2002, they introduced a financing change called the Universal Coverage Scheme. But what this shows, and what the Thais also show, is look, for 20 years before that, they were investing in supply-side development, rural health service development, nursing, scaling up the district health system, a whole range of things which were happening, and then little bits and pieces on the financing side as well. So you had a lot of this. It was all embedded in an overall national economic and social development plan, and so on. And so this is really a nice illustration of how different pieces of their system work together over time. And this last one as well, which was basically the Health Systems Research Institute and the International Health Policy Program, the very strong evidence to policy links that exist in the country, which is also why we know a lot about what's happened in Thailand, because they're very good at documenting and analyzing and anticipating what to do next. So why does this all matter in South Africa? Again, this idea of UHC being embedded in or including these objectives, but very much, and going back to some of the countries I showed, that a big part of the agenda in many countries is to address current inequalities that are legacies of the past. And that has been very much the case in Thailand. You remember that older slide I showed in terms of the inequalities there, in Mexico as well, where a big part of their agenda is to, at least, if they couldn't merge all of the schemes into one, again, because they couldn't fully overcome the historical legacy, to at least try and raise the level of subsidy per capita sufficiently for the part that serves most of the people in order to reduce the inequalities between these. In South Africa, it's very much a constitutionally driven agenda to equalize things, as well as I would imagine a very important political issue given where the country was coming from, and the fact that in some ways things may be worse now in terms of inequalities in the health system than they were in the last years of apartheid should be seen as a very serious political problem in the country. So the plan, I think, is on balance that I've seen, although now it's a little bit unclear where it stands, but basically it is focused on this redistributional agenda. It also gives a lot of attention to the efficiency dimension as well, with the recognition that it's not simply about raising more money, and realizing as well that South Africa is not a low spender. It's just that the prices are incredibly high in South Africa because the private medical sector is driving up the costs of everything. And like I said here, I'm only not entirely sure what is in the current plan because the white paper, as it's called, the final policy paper, has not been released. And while we've had some inputs into earlier versions of it, we don't know the latest dynamics. We don't know if the current minister will stay minister and how things might change. But certainly, the supply side has been very important. And as I said, primary, while most of the problems in that slide I showed about some of the areas of need, primary care can respond to most, if not all of those. It may be more an issue of the politics and the expectations of people in terms of the very high cost system that serves the well-off, and how to manage this transition and how to manage the expectations, and as happens in some other countries, convince people that primary health care is not second-class kind of health care is important. So this is a big challenge. So just finally, in terms of some of these messages, that for UHC, addressing inequalities is really at the core of the UHC agenda. And fragmentation in the way systems are organized is one of the major targets for our support and reform agendas. In South Africa, unfortunately, it seems not much has actually changed in the structure of the system since 1994. It's also extremely expensive, and just throwing more money at one side of it, there's probably not enough money to do that. So really focusing on the efficiency agenda, and hence, I mean, apart from other aspects, but in the basic words of economists, if that the PHC-led approach is really essential for efficiency reasons, if not many other reasons as well. So that's anyway. That's just some reflections on this, and let's open it up.
I'd like now to pass over to my co-organizer, Professor Sanjoy Bhattacharya from the WHO Collaborating Center on Global Health Histories at the University of York, who will facilitate the discussion.
So as Human said, my name is Sanjoy. If I could just remind all of you, when you make a comment or ask questions, please identify yourself. There'll be people online listening, so it'll be good for them to know who's asking the questions or making the comments. I'd also like to record very quickly my thanks to Human Momen. It's an emotional day for all of us who worked on the GHH project for 10 years with Human. That time just passes and Human is about to retire, and the 80 seminar mark would not have been possible without his energy and good counsel. So I wish my friend well, but he will be missed. But we will also work very hard to try and maintain the high standards he has set of independence, excellence in scholarship. And as he said, none of this would have been possible if the Wellcome Trust, which is an educational charity with no links to pharmaceuticals, as some people mistakenly believe, hadn't taken a punt. It was a punt because they hadn't funded an international program like this before we started. So heartfelt thanks to them as well. But I wish my friend well. Maybe I should not ask a question right now, and I invite questions from the field, from the floor. Sir, please use a mic, please.
Thank you. My name's Andy Ramsey from PDR. So thank you very much to both of the presenters for really interesting, really stimulating presentation. I've got a question, I think, for each. First, for Dr. Noble. I wonder, during this period, I worked in Southern Africa during this 80s, 90s period for most of these years, and I wonder to what degree you think that the frontline states and training of activists, anti-apartheid activists in primary health care in the frontline states contributed to the development of PHC in South Africa. And for Dr. Kutzin, the elephant in the room, I guess, is to what degree the current health systems reinforce the racial inequalities. We know that it's unequal because of income, but to what degree it reinforces the racial inequalities that was the legacy of apartheid. And if you're to change that, if you're to try to, I imagine the medical insurance scheme is really between insurance companies and providers of healthcare, and how you can alter that.
The influence of places like Tanzania, where many exiled activists went as part of their exit out of South Africa, either staying there or obviously moving on to other places, the USSR, a variety of other places, where social forms of medicine were being encouraged, and obviously primary healthcare. So yes, just thinking of people like Kutzin and Dlamini Zuma, and that those individuals were, going to these different frontline states and were very much influenced. I mean, another health minister, Mantu Shabalala, was trained in the USSR and as part of that exiled, cadre of individuals, and were doctors. So certainly that's why when I started the talk, I said it was a combination of things going on in South Africa that was obviously stimulating these initiatives and movements, but also obviously what was also happening internationally. So yes, I would agree with your statement.
Well, thanks. I was going to start by saying I don't know and then talk for a while, but I think in terms of, to what extent is the divide still racial? Well, probably Dr. Noble knows better. My understanding is that it's still predominantly that, but there's a growing number, for example, of Black civil servants and others who might also be insured as well. So I think it's probably more interracial than it almost certainly is more than it was. I think in terms of how to alter, there were two broad approaches to think about how to reduce fragmentation. One is to really try to minimize the role of the schemes by basically introducing most coverage is still employment-based. And so one idea was to institute an employment-based tax that would go into this national NHI pool, which wouldn't say that it wouldn't end the scheme coverage, but if employers wanted to also offer the private medical scheme coverage, they'd have to do that on top of it. So that was one, and that would get some of those resources that are currently going into the national pool. The other option, which was, as the last, was never really taken, but was certainly always there, was to do something more like, in a way, ironically, the Dutch system, in a sense, which is to basically say that we're going to actually create a redistribution that, in a sense, everybody gets private medical scheme coverage. But it's compulsory, and a lot of it would be funded from taxes, and that would be pooled together with these contributions, and then people could choose there. And either of those, actually getting rid of or minimizing the schemes or universalizing the choice of schemes, could both, in effect, address that redistributional problem. The second one, with the competing social health insurance approach, is very difficult to manage administratively, and it requires a very strong data foundation, and for a variety of other reasons, also the fact that they didn't think it would be very effective at putting pressure on providers through purchasing arrangements. They haven't gone for that. And it looks like the NHI, the financing approach, will be more the first. How far they're going to go with this tax policy, I don't know. And that's, I think, one of the things we're waiting to see, because I think while there was this strong racial divide, it's now, of course, the civil servants are benefiting from this as well. And that's always a challenge.
Can I just add something? Just to add to what Joseph was saying, in South Africa in the last 20 years, there's, been obviously a huge increase in the black middle class itself. So class, it's important to note that obviously race is still a significant factor, but there's also this class divide now that, if you go to any of the private hospitals, I was just telling Human, I think it was still earlier, that my mom went in for knee surgery. And, many of the, 20 years ago, those hospitals would have been white hospitals. But now, many of the individuals in the beds are, wealthy African or Indian or people of mixed race, colored people. And so there's a growing lobby group amongst Black South Africans to maintain the private sector because the services are so much better in terms of, you know, the quality of care and the skill level, because that's the place where the health workers want to work because they get better wages, with better working conditions. So that brain drain away from the public sector is essentially continuing, and there's this growing black middle class that's also encouraging that. They want those good services and they deserve those services. So it's with everybody.
Yeah, sorry, just on that as well. It's also a part of this agenda is to think about contract, that the public system could contract some of the private providers as well. The difficulty, though, is the prices, that the prices, and our office has actually just done some study now looking at pricing, private sector pricing in South African health system, in part because they need to create the precedent and show that in countries like here in Switzerland or the Netherlands, or that even in the pure private sector, government has a role to play in regulating those markets, which is less the case, I think, in South Africa. So if they're actually to be able to do this and be able to contract in private providers, they have to figure out a way to get the prices under control, and that's a big issue.
Comments, questions? Madam.
Hi, Julie Samuelson from the HIV department. Thanks for very interesting presentations. My question is more on the historical angle, although you can take it out into the second presentation as well, but it's related to the nursing community. And if you look also at the role of the nursing institutions and the nursing cadres in trying to move towards primary health care.
That's really from me either. Nursing has not been really a major focus in terms of my research. I've got lots of other colleagues in South Africa that do focus on the nursing part of the story. Yes, but I can answer that certainly even before after the medical school tried those experiments in the 1950s and then it was quashed, there were initiatives made at some of the nursing schools in the I think it was the late 70s, early 80s, but I could be mistaken, to create or to encourage the training of nurses in primary health care, because as Joseph was mentioning earlier, the issue of fragmentation in the 1970s and 80s becomes enormously problematic in South Africa's situation with the Bantustans, the creation of separate development areas. And many doctors, there weren't enough black doctors to essentially go out and work in those areas. Many chose not to do so because of the bad conditions. And so often nurses had to carry the brunt of the medical care services in the health clinics in the Bantustans. And so they were trained to be given more, that's what I'm looking for. It's often doing services that doctors would have done in those health clinics because essentially there are no doctors around, or the doctor would only come once a week or whatever. So certainly in the they called in polyclinics and small clinics in the townships and in the rural areas, there were yes, there was training of nurses to essentially carry a lot of those responsibilities, and so primary health care was encouraged there, but not so much in the medical student training side, which I know more about.
Madam.
I have a bunch of questions. My first one is your terminology, and I'm just always interested in how terminology and how you use that term Indian. And yeah, my name is Kate Gilson. I'm an intern here in non-communicable diseases. Sorry. And so I'm really interested because we use this term African Americans in the States, and I'm always a little bit, then what do we call Africans that come to the States? So A is my question about this terminology, Blacks, Indians, and is that changing, and does that change the culture? Second question I have is emergency care provided like we allow it in the United States, where emergency care is provided for anybody? And my third question is, what is the ratio of patients to doctors? And I had a fourth question. Oh, if my understanding, and I could be wrong on this, is a lot of people from Africa go to South Africa for medical care because it is the gold standard in Africa. And so it's a mixed question of, well, if you didn't have this racial equality, like I know the British were in Kenya, and I'm just using that for an example, do you have that inequality in a country that is prominently Black versus a country like South Africa? So I'm kind of asking I'm kind of forget what I'm asking now, but sorry, but what, you set up a kind of negative picture on what's going on in South Africa, but compared to the rest of Africa, it's the gold standard apparently. So those are my 4 questions, and I thank you.
Okay, the terminology issue, yes, it's a complicated one, and I deal much more with it in my book that's just come out. Certainly, the racial terms that I was using, African, Indian, coloured, white, those are terms that during the apartheid era, those terms were used, but there were also other terms used. So, for example, Bantu for African, or non-European, or Asian for Indians. In South Africa today, many people, there is contentious issues around race and obviously the terminology, particularly amongst the coloured community, the racially mixed groups of people. But Africans tend to identify themselves as African, whites, Indians, they call themselves Indians. So I was using terms, and I explain this in my book, that it's commonly used in South Africa, but obviously being aware that there are people that question terminology all the time. So yes, thank you for that question. That is, it is an issue. Terminology in terms of changing, whether it's changing and whether race is becoming less of an issue, no, it's still quite strongly there. So yeah, it's a complicated issue that's going to take a lot of time to get. Look at the United States. Race is still very much a contentious issue. In terms of emergency care provision for anybody, it's a complicated thing, because usually if you're in an accident, for example, and this was during the apartheid era, if you were conscious, you would be asked as the ambulances would come. It was very contentious, because if it was a white ambulance and it was a black person on the side of the road, they wouldn't pick that person up. Essentially, they would have to wait until a black ambulance was called to fetch those people. If, say for example, it was a white person that was hit by a car and they were conscious and a white ambulance fetched them, they would be asked, do they have private medical insurance, or are they being taken to a public hospital? So it was very much, and I remember this from my mom's generation and my grandmother, they always wanted to make sure that their medical card was on them. So even if they were unconscious, or on their medical bracelets or whatever, that would be a big issue, that you're taken to a private hospital because the services are much better. Today, the public, if a person gets hit and they're unconscious and there's no evidence of what if they're privately sponsored or privately insured or not, they would be taken to the closest public hospital first. And then patients to doctor ratio. In terms of that question, are you asking about now or in the apartheid era? No, I have no idea. I can tell you more about that in the apartheid era, but today I don't know what the specific ratio is. Other Africans going to South Africa for healthcare? Yes, certainly there was. And you say this idea of South Africa being the golden standard. It's interesting, because with all the problems, it was the golden standard, and that's, as Joseph was saying earlier, it was a medical care that the part of it that worked, that was highly technical. It was like trying to copy Britain, or trying to copy some of the highly specialized, in South Africa with the white doctors, many of them in the early years, say for example the earlier 20th century, were being trained in the UK and in places like the UK, particularly because of South Africa's connection to Britain. And so they were learning all those highly technical, curative, hospital-based approaches. They come back, work in South Africa, train a whole generation of new students in that particular model. And so that was used as the golden standard of what was good technical health care. So there's always been this long tradition of primary health care being seen as the secondary. It's not the greatest. It's not highly technical. It doesn't require the skill level that a highly technical surgeon needs, or working with very highly technical equipment. So sure, South Africa was the golden standard for technology, but whether that was the best, way from.
I think it's this distinction between it's not about the best health system. It's where would you go for the, maybe the best top end hospital, but that's not a reflection. It's not available to most people in the country. Yeah. The other thing that came to mind, it was a joke, well, sort of a funny story, that a guy, Uwe Reinhardt, who's a U.S. Professor of health policy at Princeton, would always put up, when he's talking about this issue around emergency care, and so on. And he would show during his presentations, one slide would be of his underwear, which were very expensive underwear and you know, lots of colors and so on. And he basically used the same rationale that if I'm in an accident and I'm unconscious, I want them to think I'm insured. So that is something that also cuts across country lines as well.
Just say something more too in terms of the Africans coming from other countries to South Africa. Certainly by the 1980s and even the 70s in some areas, like Kutzin Hospital in Cape Town had a segregated section. So it was the one hospital that treated blacks and whites and coloreds, and you know, it was all very fragmented in terms of the wards. But certainly if the person, you know, needed to come and have heart surgery done at UCT's Kutzin Hospital, and they had the money to do so, to come to that, you know, that area, then essentially yes, they would be treated, but they'd be treated in segregated wards, and yeah, but they would get technically very sophisticated treatment, yes, but at, you know, what cost?
Hi, thank you very much. I'm an intern in the health workforce department. So I have one comment and one question. Going back to the topic of our seminar today, indeed the history was very encouraging, but I'm a bit skeptical about the fact that we link social activism with fighting for primary health care. I would like to use China as an example. If the people fighting for universal primary health care are social activists, primary health care will not happen in China because of the political commitment. So, so this is my comment about like whether we can use the same history and apply it to other countries nowadays. So but my question is, I'm really interested in what was exactly the turning point of having the political commitment by South Africa to go towards primary health care and then democracy. What was exactly the link, and who, what factors were influencing this process? It would be nice if you could provide more detail.
Okay, very specific question. I would say the political commitment was, in terms of anti-apartheid activists, I would say was there from at least the 1960s, okay? But the problem was that when the ANC, which was the ANC African National Congress, was the strongest, obviously, anti-apartheid organization operational in South Africa, gets banned in the 1960s, a lot of that, the drive is the ideology of and linkage of primary health care to an activist thing. It was in people's minds, and people were committed to it, but essentially the major organization that would want to drive it was pushed underground or overseas. So this is what I didn't really speak about in my talk, is that there was a lot of individuals in the exile community in places in other southern African countries, but also East African countries, in the USSR, in the UK. There were these activist communities all over the place that were discussing primary health care and figuring out a way, if South Africa gets political independence, that would be the best way forward. So you've got these organizations within South Africa itself in the 1970s and 80s, like I mentioned, the National Progressive Primary Health Care Network, health workers in the United Democratic Front, talking about it, not really being able to do anything about it until the political transition comes, which is why what you were saying, the link between actually what's going on in politics and what policy implications then follow from that are centrally linked. So the discussions are going on in South Africa by these political anti-apartheid organizations not having much power. Lots of discussions going on overseas, learning from the World Health Organization's Alma Ata Conference and all the other programs that are being developed across the world. And then in secret discussions, people from both sides are essentially talking to each other and trying to plan the way forward. And so by the late 1980s, when apartheid was starting to essentially crumble at all levels, those discussions become increasingly, heightened. And when the banned organizations like the ANC and that are individuals are allowed to start coming back to South Africa, the discussions become much more open and public and what's the word I'm looking for? Not underground, not hidden, or carefully discussed things. So I can't like identify a specific moment. So it would be, it's almost, you know, that history hasn't been written really about the discussion between what's going on between the exile community and what's happening in South Africa. That story still needs to be really fleshed out and discussed. And then to be able to create that, you know, identify one specific moment when that's, I can't answer that. I've got no idea. Do you want to say anything?
No, I don't. Okay. But if I could quickly add something, most anti-colonial nationalist movements had a lot of doctors in them. Yeah. And when they were talking about primary healthcare, it's not necessarily today's definition of primary healthcare. It simply meant providing some sort of care to huge numbers of people who had no care. So a good historian would try and define primary healthcare on the basis of the definition used at that time, rather than taking today's definition back. About the Chinese example, there are, I think, 2 or 3 official historical narratives of what happened with the Barefoot Doctor scheme. What unifies them, because there are different political regimes sort of supporting the writing of those histories, the unifying thing is that the primary healthcare system is presented as a monolithic, a unified system. But very recently, some very, very interesting work has begun to come out. In fact, our first speaker last year, Fang Xiaoping, who's Chinese, now works in Nanyang Technological University in Singapore. I would encourage you to listen to the recording or read his book. He actually talks about disjunctures in the Barefoot Doctors movements, where actually some doctors were social activists, speaking up against what they thought was political repression at that time. So alternative histories are coming out, especially from very bright historians like Fang Xiaoping, who are also working in Singapore, which probably makes it easier for them to write what they're writing. His father used to be a barefoot doctor, and therefore he has access to amazing material which others don't have. So I would encourage you to read up as well. I think the library, please, last question.
Okay, my name's Shruti, and I work in the medical devices department. I'm an intern, also in essential medical technology. And so Dr. Kutzin, you just said something about the fact that sometimes technologies aren't always available in parts of the country to really, you know, push forward medical care. And so I study engineering, and whenever I hear technology gets me excited. But in particular, I think when there's innovations in medicine, you really do push the boundaries. So how do you think we can start bringing more technologies to maybe lower research or more widespread technologies? And that's a big question, but what would be, because I think for medical technologies, it really does depend on, again, that whole concept of redistribution of wealth. And
well, I mean, again, I get to talk about things I don't know anything about. I mean, all I would say is from the aspect that I know something about it, that's more about sort of establishing the preconditions to make something like that possible. It's not to say that if you had in other words, without a more redistributive financing mechanism, it's going to be very hard to really reach remote areas and poor areas unless you greatly increase the level of investment. But just having a more redistributive system won't automatically make it happen. It's more about setting the preconditions. So it's also, I think a big part of it is also to think about, to have a plan in a sense for what's the way we want to organize services for different parts of the population, meaning literally different geographic areas in a sense, because your service delivery strategy in a highly densely populated urban area should be different than in a rural area. You can't rely on, choice and competition in rural areas, for example. So in a sense, if there was a plan like that, it would need to include what you're discussing. It may include things like, using whatever it is, the imaging, remote imaging type of thing, so you can take the scan in one place and read it somewhere else. And all you can do, I think, with the financing mechanism is help create a platform for that it can happen. But you would need, people like you and others, to kind of come up with the actual what to do. And then it's for people like me to help my part of the system get out of the way, in a sense, to enable that to happen. Because right now, without the platform, it's basically going to be very difficult to sustain what you're talking about, to reach remote areas over the long term. You might be able to do it through a special project for a while, but you really need to have this foundation of a system that is really reaching different places, getting resources out in accordance with need, and then to come along with the creative solutions about maybe how to do that most efficiently. So I'm not sure that's an answer, but it's at least an attempt.
I'd like to thank all of you for joining us, and also thank two wonderful speakers for their contributions. I'd like to thank Miriam for continuing support, and I'd like to introduce Jing, who's going to work with us on the Global Health Histories project for the coming months, and a humanist person. Thank you all. See you again September. Thanks.